Broad in listen-only mode.
Dr. Matthew Boes, fellowship-trained sports medicine at Raleigh Orthopedic Clinic, will be discussing shoulder and elbow injuries in throwing athletes. If you answer throughout the webinar, please type them in the questions box, and we'll answer the questions at the end of the webinar. And the webinar will be posted on our website after the presentation at www.raleighortho.com. And here is Dr. Boes to begin the presentation.
Everybody. Today we're talking about shoulder and elbow injuries in throwing athletes. Dr. Matthew Boes, I'm one of the physicians at Raleigh Orthopedic Clinic, and I have the privilege to work closely with the North Carolina State University baseball team. What I'll give you an update on today is kind of the current theory for how we think that shoulder and elbow injuries develop in throw. And really this has to do with injuries to the labrum in the shoulder, to rotator cuff tears, and also ulnar collateral ligament injuries in the elbow. Those are the three main injuries to throwers. That the injuries to these structures occur along kind of a specific injury cascade, and the reason that's important and why I wanted to present this to you today is that we can identify early stages of this injury process and intervene and actually prevent a lot of these injuries. A little bit older, but I think a picture says 1,000 words here with you know, the high magnitude forces that are involved in pitching. And it's important to remember that these are repetitive forces for throwers. This could be, you know, over 100 times a game and oftentimes several days a week. It's been divided into several stages, and these kind of help with biomechanical study and analysis. For our purposes, we're going to kind of generally group them into three different phases. You have initially the wind-up and early cocking phases, where energy is stored in the larger muscles of the body, the legs, hip, trunk, and shoulder girdle. This goes to a cocking and then acceleration phase of the arm, where the energy is transferred through successive body segments, starting down at the foot, into the hips, trunk, through the shoulder and elbow, all maximizing velocity of the arm at ball release. Focus on where all the problems occur is in this deceleration and follow-through phase, where after the ball is released, the arm is flung forward, and essentially the shoulder muscles and the rear shoulder muscles have to contract to absorb all that energy that's been stored and then dissipated. And there's a significant distraction force of the arm that's up to 1.5 times the weight. Comes through. There's huge force on the back of those arm muscles that have to absorb that force. Follow through. What causes most shoulder and elbow problems in throwing athletes? And it's overuse and muscle fatigue, and we'll see how that causes the successive kind of injury cascade that I was talking about in the beginning of the presentation. And this has been fairly recognized. Baseball America did a study, 10-year period. What they looked at is all of the essentially rookie prospects that came into the league that had a chance to pitch at the major league level right off the bat. And we can see that all these kids, they've been going along, they've been pitching, they get drafted into the major leagues, they're ready to go play, and 20% of them have a elbow injury. Not that keep them out for a few days, but this is 1 in 5 have an injury that requires surgery, and then 1 year on the disabled list. And clearly something's been going on as they've been pitching all this time trying to get to the big leagues. A great article in the New York Times several years ago that talked about this, where you know, the subject was, are we stressing young arms too much by really having them pitch too much, and what the effect of that was. And this author looked at, if you looked at a 10-year period, the top 10 rookie major league pitchers in terms of innings pitched, and you see that right here. astounding that 7 out of 10 of them had some type of injury to the shoulder or the elbow that required surgery. Overuse and fatigue play a role in this. We're into Dr. Jim Andrews down in Alabama. Most people who watch SportsCenter are familiar with him. They actually have a very nice research facility down there, and they've looked at risk factors for young adolescent pitchers aged 14 to 20, risk factors for them developing injuries to the shoulder or elbow that require surgery, and some of those are listed here, some of the more common ones, to do with overuse and overstressing the shoulder. Regular throwing with arm discomfort, that's essentially throwing with chronic shoulder fatigue. This one's interesting. If a player pitches for more than 8 months consecutively throughout the year, that increases their chance of developing a shoulder and elbow injury requiring surgery by 5 times. And this is important because this is kind of a new phenomenon. We see these club teams and kids who essentially play only one sport, and that's baseball, and they play it year-round. And that may be, as we're seeing here, detrimental to them. Now, I'm not going to get too much into pitch counts today. How do I go back there? So I've been kind of at fairly extensively, and I think there are some good guidelines in terms of Little League, in terms of limiting pitch counts. But if the pitch count gets high, or if you're putting too much stress by people that can throw quite hard, put themselves at risk. Now know is that there's a predictable pathologic cascade that happens, a specific sequence of pathology that leads to shoulder and elbow problems in throwers. And it all starts off with that acquired shoulder muscle weakness as a result of the repetitive force on the muscles in that deceleration and follow-through phase as we saw in that video. Essentially what happens is there's a loss of a protective effect that normally the muscles in the back of the shoulders absorbs all that energy. What happens is that the shoulder ligaments become exposed to that force now, and they're altered, and they thicken and tighten in response to that force. And that leads to altered throwing mechanics. That altered throwing mechanics places different parts of the shoulder and elbow on stress, and with continued throwing, that's where the chance for injury comes about. So you can look at it like this, and I'm going to come back to this kind of and go through each stage. It's important to understand what's going on here so that we intervene at these various stages to prevent subsequent injury. So the first thing we look at is this shoulder muscle weakness, and we can identify this quite readily in throwers that are having problems. You put them up against some horizontal reference. This is a right-handed thrower, and what happens is these shoulder muscles weaken. The muscles that control the position of the shoulder blades, right? 18 muscles that attach to the shoulder blade and control its position. As they weaken, it leads to a drooping of the arm, and you can see this quite readily. Here's another pitcher, a right-hand thrower, and you can see this asymmetry in the both shoulders. This changes arm mechanics as the has to change their throwing motion slightly. That can lead to further irritation and injury. But mostly this is a marker for the loss of that energy absorbing function of those muscles in the back of the shoulder. This is a professional tennis player. This process also happens in other overhead athletes besides throwers. But what happens is repetitive overuse. You get fatigue and weakness of these muscles that control the position of the shoulder blade. And as a result, depending upon which muscles are specifically involved, you a dropping of the shoulder blade, it shifts away from the midline, and it also rotates away from the midline. As you lose the protective function of that muscles, you get maladaptive changes in the shoulder joint, and we can see that pretty readily here. What happens is the distractive force of the arm gets focused on the back part of the shoulder joint, okay, due to the position of the arm during follow-through. And what happens is this part of the shoulder joint capsule, this specific ligament here, ends up absorbing most of that force. You get some remodeling, thickening, and contracture of that rear joint capsule. It's very analogous to, the structure of the body reacted to various stress. the tendons, the ligaments, the bones, and the muscles. It's similar to, if you go to the gym and you start working on, lifting weights, what happens? Your muscles get bigger. They're exposed to more force, and they grow and get stronger in response. And the same thing happens to this ligament. As it's exposed to more force, you can see on the MRI, we can see when we look in the shoulder joint, if we have to do surgery, we arthroscopically in the shoulder, and we can see this thickened band that develops in here. And we see it clinically as a loss of internal rotation, or loss of this motion where the arm comes forward when it's out at the side 90 degrees. That motion is called internal rotation. And essentially this ligament, that motion, and you get a loss of it. So next slide. So what is this contracture, this thickening of this ligament presents a lack of glenohumeral, that's the medical word for shoulder, internal rotation. And we can see on the left side here, this is a right-handed thrower. He's tight, much like he is in the non-throwing shoulder, just by measuring those angles. We look for the difference between the rotation on the throwing side versus the non-throwing side. And that difference is the internal rotation deficit. So what this is referred to as is glenohumeral internal rotation deficit, or GIRD for short. We'll talk about this 180-degree rule. It's important to understand that, for the most part, the motion of the shoulder going back into full wind-up or fully externally rotated position to the fully internally rotated position in a thrower is generally about 180 degrees. And we do know that in throwers they generally have more external rotation, so they can wind up more fully than they have internal rotation. And that's normal, that's adaptive. The problem is when that internal rotation becomes less than the gain, the external rotation. As you see here, this is quite abnormal. He's just able to only internally rotate past vertical, and that indicates significant contracture in the back part of the shoulder capsule. Well, why is this important? This point is the biomechanics of the shoulder get altered, and the throwing mechanics get altered, and that's where it's a setup for stress on the shoulder and risk for injury. So this is a slide that can be somewhat confusing when you look at it at first, but essentially we're looking from the side at the right shoulder. And it's on the ball at the top of the arm bone is kind of superimposed at the socket. So here's front ligaments, back bottom ligament that gets thickened. And if you look at the top, the biceps tendon comes up, goes over the top of the shoulder, actually attaches to the top of the socket and becomes the labrum, which surrounds the rim of the socket. And the reason I'll show you this is to see as the arm goes from the neutral position, which is at your side, the elbow comes out. So picture, you can see the arm in cross section now because the arm is away from the body and wraps like a wind-up position. What happens is that ligament, that back ligament, shifts down underneath the ball. It's thickened. It pulls it up and tears it back. And what happened is that through the biceps tendon, that puts more stress on the top part of the labrum and more stress on the rotator cuff and sets us up for injuries that we'll see. Now, if this happens, the pitcher can kind of sense this. Over time, this starts to develop, and there's conscious or unconscious ways that throwers will try and work around this kind of tethering in the shoulder joint. So what they start doing is they alter their pitch mechanics. Instead of the arm in the wind-up position being in line with the shoulder blade, they do what's that's called hyperextension or horizontal hyperextension of the shoulder, where they'll bring the elbow way back behind the plane of the shoulder blade. They'll go into some extreme external rotation or accentuated wind-up position. In addition, the angle gets less as they try and overcome this contracture in the shoulder. And all three things all mechanics enough that it puts the both the shoulder and the elbow at risk for injury. So what you have is tension and stress on the upper part of the labrum. Here's the rotator cuff as it comes across and attaches here. And you can picture as the arm is more externally rotated and extended behind the body, you're going to put that rotator cuff on more tension and more stress. The risk for problems is as this kind of starts, the pitcher is able to throw, but they kind of go through this early stages where they have vague tightness, difficulty getting loose. They may note that over the season they have problems with some discomfort in late or full wind-up position, loss of velocity and loss of control. And all are kind of early symptoms. If the pitcher continues to throw at this point, they're at risk for developing actual structural injury. And works. Essentially, all these throwing changes put stress on structures in the shoulder, most notably the labrum, but also the rotator cuff. As the arm bone, as the ball is shifted back in the socket, there's more clearance of the ball from the socket, and so you can really hyperextend and put the labral and rotator cuff structures on a lot of tension. I'm going to go back. Where particularly is into the labrum. So if we look here, the biceps tendon comes up. This is the socket as viewed from behind. Okay, and what happens is, as you go into extreme external rotation and extension in the wind-up position, it puts a torsion on that biceps tendon, and through the biceps tendon, the top part of that labrum. The top of that labrum can fail and become unstable and actually shift back on the socket in that full wind-up position. And this is the principal injury in throwers. This is the one that that them get to a certain degree. This is the quote-unquote labral tear. And when this happens, when you develop this instability, the player is no longer able to throw at their previous level. And 9 times out of 10, it's going to require surgery to anatomically repair this to be able to throw at a high level again. It's in the OR. This is actually a pretty good demonstration of it. I'm just orienting you here. Here's the patient in the OR. They're lying on their side. Their head's up here. Their feet are down here. Here's their throwing shoulder. It's a right-hander. And what we're going to do on this video on the left is go from a neutral position to the locked or wound up position. And what you'll see is that labrum unstable and kind of falling off the rim of the socket. Here's the socket. Here's the labrum right here. Okay, and normally that's nice and attached to the rim of the socket. And into that full wind-up position, you can see it just falls off like that. And it'll be a fairly subtle injury. It's important to remember that pitching is a high-level and very specific function. This may be able to do most normal activities in their daily life. In fact, you know, when we see throwers, let's see that one more time, with stuff around the house or any other activity they do besides throwing. The problem is that when you have even this subtle level of instability, and this is a good example of it, it causes enough pain when you're trying a high-level activity like throwing that you're unable to do that. And that's why this is important. In the kind of early phases, this can progress to actual injury. And as we described, the injuries that we're talking about is injury to the top part of this labrum. Here's the socket. It's also called the glenoid. You're looking at it straight on from the side here. And the labrum is normally this kind of gasket rim that attaches around the socket and kind of tends to deepen a socket. Down the bottom part in the front, and it's an attachment site for ligaments. In the top, it's an attachment site for the biceps tendon that comes up from the arm. And these labral tears, they're like two edges of the labrum flapping in the breeze. It's a little bit more subtle than that. It's almost like, the way I describe it to patients is kind of the bike tire comes off of the bike rim to a certain degree. And you can see that nicely. Here's a picture from in the OR. Here's the biceps tendon. Here's the labrum. Here's the top of the socket. And this space is abnormal. For information, this is a picture of what it looks like when we fix that. What it's involved is you put some anchors down into the bone, and they have these sutures attached to it, and you pass sutures around the labrum and tie it back down. get that to heal up back down to the rim. That's what it looks like when we do a labral repair. It's also rotator cuff tear. Remember that twisting in that hyper-external rotation. On the left side is a normal rotator cuff. Here's the top part of the ball. Okay? Normally, rotator cuff has nice, smooth fibers that look nice and confluent that come down and attach into the top part of the ball. And if you look over here, here's where fibers have been disrupted. And actually, this patient has a full-thickness rotator cuff tear. You see with throwers, there's a type of partial injury to the under the joint side of the rotator cuff. Those are the fibers that are most affected. But occasionally, you do get some full-thickness tearing of the rotator cuff, which is a significant injury for a thrower. 10% of the patients have some shoulder instability or looseness of the front part of the capsule, or part of the shoulder ligaments. This was previously thought to be the primary lesion. It occurs only in about 10% of people. It's due to being able to really go into extreme external rotation here. What that does is it puts the front ligament on stretch. Also, if we look down from the top, here's the ball, here's the socket. Remember we talked about that ball getting tethered back in the socket, and as that happens, it leads to some relative loosening of the front ligaments. You see that to just repair that looseness in the front, and that's only minimally successful in restoring throwers back to full activity because it ignored the primary injury, which was the labral tear. That's why it was only partially effective. The elbow, all these that I'm talking about affects the elbow as well. We're all familiar with the ulnar collateral ligament, also known as the Tommy John ligament. The operations that I'm talking about in the joint and with the throwing mechanics are the reasons for why people develop ulnar collateral ligament tears, and it has to do with the fact that the arm angle is altered, that the arm is brought through a position where the ulnar collateral ligament for a longer period of time during the throwing cycle, and it leads to more stretching and more risk of injury for the ulnar collateral ligament. And this has been shown pretty really with biomechanical studies. Sometimes this early on, this is Jeff Cooper, the head athletic trainer for the Philadelphia Phillies. And it seems kind of counterintuitive, but he says most symptomatic elbow problems in throwers are actually coming from the shoulder, which may be completely asymptomatic, meaning that you don't have any problem at all in your shoulder, but it's causing problems downstream, and it's due to all of the changes that occur in the shoulder, how it changes, how it affects the throwing motion, and how stress across the inside part of the elbow joint, right where this ulnar collateral ligament is altered across there. And essentially what happens, due to that repetitive stress, there's stretching of the ligament, and it gets what we call attenuated or stretched out. It's functionally incompetent and causes pain when people throw. The nature for how these things develop, and I apologize if that was a little bit confusing. It's a complicated mechanism, and complicated if you're not familiar with the anatomy and that kind of thing. But the base is that there's kind of a progression that goes on, and so what we can do with this is then work on preventing the pathologic cascade in our throwers, and that's done through recognition of various problems and then focus rehab to try to alter the course of this, and we'll go through that. So the point is that all of these top steps that I'm talking about up until actual structural injury, these can all be prevented. Look for evidence of shoulder weakness, and that's represented by asymmetry in the shoulder blades. And I'd invite anybody out there who has, say, a son or a daughter, someone who's a regular thrower, who's complaining of shoulder pain, that might be why you're watching this video. Look at them from behind, in front of some type of horizontal reference, like a bookshelf or that kind of thing. Last when we'll have kids with their parents for evaluation for throwing problems. And I'll just have the kid take their shirt off and stand up in front of some blinds like this. And you even really have to point out to the parents. Just kind of looking at that reference is something that they haven't it's kind of a way of looking at the shoulders they haven't seen before, and really readily apparent to pick up this asymmetry, and indicative of significant muscle weakness and kind of the start of this cascade. It's important to look for any type of internal rotation contracture, which is a sign of thickening of that ligament like we talked about. There are focused exercises that you can do to work on building up all those muscles that can that shoulder blade position. And you can be very successful in doing this. It usually takes about 6 weeks, maybe 3 months. But reduction of any type of discomfort or any problems in the shoulder and elbow usually comes with restoration of normal symmetry and eliminating any asymmetric shoulder position due to these strengthening exercises. I like this because it really shows how with some focused compliant rehab, they've really been able to normalize the shoulder position, but also you can see how well developed the musculature is in here compared to over here where he's significantly asymmetric. And 95% of throwers are able to resolve their symptoms by 3 months if they're compliant with the daily program. Most earn by 6 weeks. Now what about this internal rotation contracture, that internal rotation deficit? Headed to Chris Verna, who was the athletic trainer for the Seattle Mariners in the early 90s, who initially identified this as the cause of shoulder and elbow problems in throwers, and noted that of their players with shoulder and elbow problems, he followed them by measuring their shoulder motion, all 39 major league pitchers through one season, and he said that they all had significantly limited internal rotation. That was the one kind of common denominator, and 85% of them developed some significant problem with the shoulder and or the elbow throughout the course of that season. And these what are called sleeper stretches for short. They're a focused stretch that works on the back bottom part of the shoulder joint capsule and can involve that contracture that we talked about here. And here's down there lying on their side, and then there's force to the arm to kind of gently stretch out that back bottom portion of the capsule. And these are done twice a day, and there's kind of the regimen how you do it. These are some more advanced stretches that work on, again, that back bottom part of the joint capsule to try and resolve that altered biomechanics of the shoulder. This is shown clinically to be very successful. I put in a couple examples here. Again, remember we talked about other overhead athletes can be affected by these problems besides baseball players. Dr. Kibler at the University of Kentucky looked at his Division I college tennis players, broke them down into 2 groups. One group had daily sleeper stretching, sleepers like we just showed. The other group had no stretches, and he had a 30% decrease in shoulder and elbow discomfort and shoulder and elbow problems within the stretching group compared to the no stretching group. This is the most impressive one is Jeff Cooper again. We mentioned him before with the Philadelphia Phillies. So over the course of 3 months, he was a component of this internal rotation stretches, and he took all of the 22 pitchers that they had on the Phillies roster over the course of those 3 years and stretched them daily, kind of up the net on these guys, got them into the training room, and made sure that their internal rotation deficit was less than 20 degrees. And it's fairly remarkable that over the course of 3 years, no surgical procedure, they had no shoulder and elbow injuries, they had no innings lost. I mean, these were people that over the course of 3 years in your pitching rotation, you never had anybody lose a start. So clearly this is quite effective. Well, Morgan up in Wilmington has looked at this. I spent some time with him in my fellowship in Philadelphia. And in terms of treating elbow problems, what you do is ignore the elbow, focus on the shoulder, throwing, okay? Focus on doing sleeper stretches to revise or to resolve any contracture in the shoulder, and then once the internal rotation deficit is less than say 20 degrees, have people start throwing. What he's found with this is that using this type of protocol, 92% of patients with the inside part of the elbow are able to resume pain-free throwing at the pre-injury level by 6 weeks. And that's by simply focusing only on the shoulder and not doing anything with the elbow. The remaining 8% usually, in this case, in the case of his study, had significant injury to the elbow, and they actually required ulnar collateral ligament reconstruction. Some free throwers, some healthy throwers have minimal GIRD. There is some GIRD or some internal rotation contracture that's adaptive for high-level throwing and maximizing the on-field performance. However, if it gets up to a certain degree where that shoulder gets really tight in internal rotation, that's pathologic, and that's what we know is the shoulder who's at risk for a shoulder and elbow injury. And the issue is that, as I said before, these require surgery correct the problem so that the person can go back to throwing at the pre-injury level. GIRD, as I said, doing these stretches can prevent shoulder and elbow problems in throwers. This is what we're trying to prevent. Okay, here's a major league pitcher, injury, right. Okay, see how tight he is in internal rotation as opposed to the other side. That's approximately 70 degrees, and that's the setup for this. That's where bad things happen. A labral tear on an MRI, labral tear in the OR, as well as a rotator cuff injury, and it's all due to that tightened capsule in the back. So mapping in our athletes, the problem, doing focused rehab at early stages, and stretching. This is what we're trying to prevent. Prophylactic stretching. This is a baseball team getting ready to do some warm-ups or pregame. They're all doing their sleeper stretches. This is found to be preventive for development of any type of shoulder and elbow issues. And this is certainly, I'll knock on wood. Coach, superstitious guy, probably wouldn't like say this, but this has certainly been our experience at North Carolina State, as we've put together a program here to do stretching and specific reconditioning exercises for the guys. And it has so far had results in minimizing any type of shoulder and elbow problems. So this is kind of what we're looking at now. This 1 in 5 incidents of players come along, they hit the big leagues, and just that overuse and fatigue builds up, and boom, 1 in 5 need surgery. That's what we're trying to prevent. There certainly is a culture in baseball, and there's certainly smart and very successful people like Jim Leland in the big leagues who know a lot about pitching. But what he's essentially saying here is that you have to be able to throw a certain amount of a certain amount of innings and deal with a certain amount of fatigue. And well, true with people that make it to the big leagues, they're able to withstand that to a certain degree. The problem is this kind of mentality trickles down in the lower age groups, the college ranks, high school, and youth baseball, and it's this kind of thing, this kind of continued throwing and going through pain, which kind of sets up patients for injury. So, in summary, what I'd like you to take from this is that most shoulder and elbow injuries in throwers are the result of a predictable cascade that causes very specific injuries. Again, injuries to the labrum, the rotator cuff, and the ligament of the elbow. It starts with overuse and the resulting fatigue on the shoulder musculature. Early portions of this throwing injury cascade can be easily recognized, and focused rehab instituted to reduce the risk of subsequent injury, and prophylactic stretching and reconditioning exercises can be successful in preventing most of these injuries. And again, that's avoiding loss of performance, decreased velocity, decreased control, etc., avoiding innings lost or missed games, and most importantly, avoiding any type of injury requiring surgery. And that was helpful. Thank you very much for your time.
The very informative presentation. As I mentioned, this will be recorded and posted on our website at www.raleighortho.com.